So yeah, my name is Sigi Marmorstein. I'm actually a nurse practitioner in my profession, and in extension then a very big lover of patient care and a big believer that patient care and patient delivery should be on the forefront of everybody who does medicine. I came into telemedicine by doing my own startup in 2009 with American Well. You didn't hear it. You didn't hear that here. But we were the beta testing for American Well, and we started something that was called Medcare Live, which was the first virtual telehealth platform in California. I exited that startup just about 2015 by selling it to somebody that has never actually touched it. And that made me think about what is the problem and what are the issues and why are we not really getting telemedicine traction as we would like to have it. So there are some of us who think, or some of you may think, that telemedicine is actually failing. It failed to deliver on the promise of giving, a well-balanced care or good quality care, or cost-effective care for that matter. I am in the believer that we haven't seen anything yet. We are just on the tip of the icebergs of what telemedicine and technology can actually bring to medicine. So since I only have 15 minutes, I will do it really quickly. So this is all the hype, right? What is telemedicine? There's a lot of hype about telemedicine. It's a $1 billion industry. We are seeing, there's going to be growth of 18% and all those great things. Well, what this hype creates is a lot of people who are investing in this space without really understanding the front line of any telemedicine program. So we see we know people saying, well, the number of visits right now in the United States is just about maybe 1 billion to the primary care physicians, but only maybe 5% of that is really being done in telemedicine. So we're really not quite there yet, and we are wondering, well, what will take us to the next, level? I love this picture, because we really don't care how he got there, right? I mean, what do we care how we got here? And we know how we got here. We have a very expensive healthcare system. We are, overpaying for everything. Our patients are paying a lot of money for insurance. They're paying a lot of money in co-pays. Our physicians are leaving the business. We have less and less and less primary care physicians who are going into medical school, and less of them are coming out. We need more nurse practitioners and mid-level providers to allow us to deliver care the way we used to. So how do we get here? That doesn't matter. How do we get the guy out of the car? That's what we want to know, right? So it's going to take a village. That's really what it is. It's going to take a village. So one of the things that I found out from many implementation is that there is a process that people want to skip all the time. That process, for some reason, is cumbersome for some, but it really has to do a lot with finances. So healthcare companies want telemedicine. Physicians want telemedicine. Hospitals want telemedicine. What they don't want is to have to go through a long process to get there. They just want it now. So what do? They give the IT department endless amount of money and say, well, just go ahead and build something that looks like telemedicine for me. So they start on phase 3 here. And they just move on from there, and then they fail. And they wonder, well, how did that happen? So they go back now, and they go back into, well, let's just find a way to use the technology we already developed to fit the program that we want to develop for. So what we're doing is now we're taking something that exists, and we're trying to shove it into a really very difficult healthcare system that already have so many complexities built into it. I always like to say, let's just start with the planning correctly. Don't give me the technology. Tell me what you want. How are you going to get the guy out of the car? What is your objective? What are you trying to solve? What is the issue that exists in this system that I can solve for you utilizing technology? And which technology will then fit the best to this specific situation that we are in? And then how are we going to get there, and who is going to help me get there? So I always start with that. When I meet with people who say, Sig, we want telehealth, I said, what are your objectives? And then if you tell me what your objective are, why are you justifying this? Because reality is that yes, we could all use telemedicine, but the question is, what is justification for this specific program? So if I say I want to have a telemedicine in a SNF, which sounds great to everybody, right? We're going to have a nursing home. We're going to put telemedicine apparatus in there. Why? Because the nurses send all our patients to the emergency room. It's a very, very expensive way of doing business. That's a justification for that. But then how am I going to design that? How is that going to work? It's not about the technology. I will take, a cart. I will put it in the nursing home. That sounds really easy, put the cart in the nursing home, and then the nursing home staff will call the doctor, and the doctor will tell them what to do. That sounds like that. It's not so simple. So the technology and the operation, the implementation of any telehealth medicine program for me, and I can tell you I've done about 40 of them, is nothing short than absolute hell until you get to the other side and it works, and everybody's like, okay, thanks God it worked. But it takes a lot to get there. It takes much more than what people want to say that it takes. And that's the reason I think that we still are not seeing the kind of engagement what we want to see. It takes legal and compliance and security and a lot of different opinions from a lot of different departments. And it takes a lot of frontline people telling you that they have absolutely no time in the day to devote to telemedicine right now. This is just not on the preview. It takes a company that says that we have a very limited budget. We're only going to give you $100,000 to put a $2 million program together. And it's just not about the technology. In fact, telehealth is not about technology at all. It's about a process. And I want to talk about that because that is where I found the real rub of the sand here. So process is what really makes telehealth successful or unsuccessful. Following a process that makes sense, not to the corporation, but to the people who are going to eventually handle this process for you. So it's all about having the right people doing the right thing with the right tools. And what those tools are is not necessarily that one thing fits all, which is another thing that a lot of people have in a hard time wrap their hands around, is to say, well, does it fit? It doesn't fit all the time, then can I use something different? But if I am a hospital and I already invested in a technology, and that technology may or may not work for me, I'm going to make it work, regardless of the fact that it may not fit what it is that my people want. So my experience is, just to let you guys know a little bit of my experience, I come from a very long experience with USC Medical Center in Kaiser Permanente, Southern California. I am now the director of telehealth at DaVita, but I'm finding in every place that I go that this process actually exists. Doesn't matter where you go. It's there all the time. So the people who have to involve in telehealth at frontline people are usually doctors, nurses, MAs, RNs, and then of course the patient, which we'll deal with the last. Even though we should be dealing with them the first, we're dealing with them always last. They are the one who is involved in various levels in deciding and making the process really actually work. So when we start in the IT department and we don't involve those people in the front line, we find out very quickly that these processes that we have in our heads that sound so wonderful and great may not work for the frontline people at all. So I recommend that if you start with a telemedicine program, or if you're feeling that you want to do something like that, talk to the people who are going to be operating this program for you and ask them if this is something, A, that they want, B, that they think that they can operate, and C, is that they think that it's even valuable for their own work and product. And then once you talk to them and you decided on an idea and you say, well, yeah, that will work for us. I think we can do this. This is going to be great. Then you want to think about, well, what was going to be the process like? Who's going to check in the patients? Who's going to see them? When are they going to see them? What is it going to cost for us to see them? What are the workflows that are going to be involved with this technology? And how is that working with the day-to-day operation of any operation, whether it's a hospital or a clinic or, or a nursing home? The workflows and the decision-making that come in with those workflows can be quite cumbersome. I recently has been involved in making a workflow for one program that involved one doctor. And we have done this workflow and, kind of like looked at the flow of this sheet for about a month. And we still don't have an agreement on how is this workflow going to look like. And I tell you what's going to happen when we are done, which is the team who are implementing team is going to be done doing the whole workflow. When we'll take it to the floor, that workflow will change, probably a few more times. So actually, literally, drawing out how is this going to work on a workflow and putting in processes, policies, procedures, talking to legal, compliance, securities, billing, always billing. Don't forget that. That is a process that takes a long time. And we sometimes want to just like jump through it. What we want to go to is the tools. So people go to ATA or go to conferences and they find this great, wonderful tool that we can use. We absolutely have to bring into our system. Forget people and forget processes and how we're going to do it. It's a great tool. I just bought it. Doesn't matter that it costs millions of dollars to my company. Make it happen for me, Sigi. Make this work. And I will tell them, really, what's the process we're going to follow here? And they're like, no process. Let's just this is great. This is telemonitoring. We love it. Make it work. I'm like, all right, we'll see what we can do. So the one last person, should be the first person we talk to, but we usually talk to last, is our patients. They're like, what? I don't know about this. Why should I be doing this? What is the value for me? When you're telling me that I have to monitor myself at home 3 times a day, what do I get out of it, right? If I have to talk to a physician over an internet versus seeing them face to face, what do I get out of it? What's the value proposition? Now, we know why companies want to do this. We know why hospitals want to do it. We know why physicians want to do it. They want to reduce the cost of care. A patient is already paying, for example, I want to take my own example. So when I left Kaiser as a full-time employee and went to as a consultant, I had to continue paying for Kaiser insurance. I paid $1,700 a month for insurance for me and my kids. That was my premium. And then I had $3,600 of deductible. So now you tell me that I'm going to talk to my doctor on the phone. I just paid you $1,700 in premium to speak to a doctor on the phone for 10 minutes. That's the value proposition. What do I get out of it? So think about that when you start looking at telehealth program, is think about the patient. What do we bring to them that they would otherwise won't get? So we know in rural medicine it makes a lot of sense, right? In rural medicine, there's no other choice. It's this or nothing. And so that's why when we implemented in, places like Hawaii or Alaska or Arkansas or other places, it was quite successful because those patients had nothing and now they had something. But in an urban communities, where you do have an access to your doctor, maybe it will take 3 months before you see them, but you still have an access. What do I give you then that I won't give you otherwise? I want to quickly, I have 1 minute on the clock there. I want to quickly talk about community. Nobody ever think about telehealth as a community. We're thinking about one-to-one interaction. What is missing right now for a lot of patients is a community, is a sense of I come somewhere and I have a social interaction with it. My next big idea, if everybody said, well, what is the next big idea? The big idea is that you want to create a community around your telehealth program. So if we're going to be serving patients who are, for example, diabetic, that they don't just come to our website to see our physicians online, but we create some kind of a support community around it. So we let them talk to other diabetic patients. We let them talk to diabetic educators. We let them get information that is valuable, that is pretend to them, that they get something out of it. So they're not isolated at home seeing a physician on the phone and now never coming out of the house, that they have something, that they have a sense of belonging, that they have a sense of community. So if we do telepsych and we want to have around that, we have other patients who are anxious, other people are depressed. Now they're talking to each other. Now they have an interaction and I'm providing them the platform to do it. I'm giving them a value above and beyond seeing my telepsychiatrist. I'm giving them a sense that they are part of something that is bigger than just them. And that is I think, a value of telemedicine. So to me, the most important stuff is this. Start with them, ask them what they want, and then take it from there to your own processes to make something valuable. Thank you so much. It's been...
Good morning. Thank you for your speech. What process or problem are you guys solving at DaVita using telemedicine?
Well, I'm not in privy to talk about everything that we do, but we trying a lot of different things. And it's not just at DaVita. At Kaiser, we had the same issue. One of our biggest problem, obviously, is access. Access to providers, access to specialists. That's becoming a big problem for most healthcare systems, right? We are dealing with the fact that we can't get enough providers to see all the patients that we sign on. So access is a big issue, and we're definitely trying different modalities to bring access to our patients. But, you know, and another thing is that we are looking at processes that are larger, for example, bringing one service to our entire village, whether it be telehealth or, you know, mental health or other services like that. So we're looking at processes that are a little bit larger as well. Any other questions? Oh.
Thank you for being here.
Thank you.
You mentioned the challenge of work. By the way, is this working okay?
Mm-hmm.
Okay. Yeah, you mentioned the challenge of working within the process and the workflows that exist within a hospital. There's this other model, though, that I think we've seen a little bit in and around is now doing something with Almada, where essentially it's not so much a process that their providers are using, but it's an additional tool that patients have access to, and bringing, in a sense, their own providers. Mm-hmm. I'm curious what you think of this model and how it fits with healthcare delivery systems.
Well, I actually was involved in some of Intermountain's developments before, but I think, you know, I actually think that we should start challenging our own processes as well. So our own processes, the processes we currently have in our healthcare system, like our friend just told us, are old and archaic and probably don't work and doesn't allow us access to our patients, and it doesn't allow our patients access to us. So challenging what Intermountain is doing is challenging old processes, which I think is revolutionary, and I think it's timely, especially now that we cannot provide what we could provide before. I think telemedicine is only a tool to challenge those old way of thinking and the old way of seeing patients. And I hope that as we progress and push the envelope more and more and more, that we'll start opening our mind to thinking about the new way of seeing patients. The old ways are obviously expensive and they don't really work. So I actually, I think that they're doing something really cool. I think we'll see how it goes though. I don't think it works.
I think you put your finger on one of the key measures or the key metrics of why nothing changes. It's cost.
Right.
You know, I'm paying $1,700 a month. You're telling me I have to have a video visit with somebody?
Right.
What do you see disrupting the insurance industry to change that equation? Because a lot of the problems in healthcare revolve around misplaced financial incentives.
Right.
Nothing will change unless that changes.
First of all, you're absolutely right. I think financial incentives is why telemedicine is not as big as it should be, right? Because we're not getting reimbursed for it. So that's a big problem. I think what will change the chasm there is the constant pushing of patients asking for a different way of seeing business or getting different. I think patients are becoming the reason why we do things differently, actually. They demand it at this point. So I think the constant demand from patient for lower cost, more accessible, more convenient healthcare will eventually change the way we do in business. Actually, we're starting to see that with Medicare and Medi-Cal paying for telehealth, understanding that this is actually a cost saving for them as insurers. We see in places like Kaiser, which is its own insurance company, looking into telemedicine to reduce cost of care. So I'm starting to see that shift. It's coming. It's too slow to change. Technology moves faster than healthcare, so it's always going to be that the technology will be ahead of the game until the healthcare will catch to it. But it will happen.
Just a comment. I'd gladly accept a virtual visit if my premium went down.
I agree with you on that. Okay.
Thank you. So I'm kind of curious about your building a community. So I sit on a pretty good-sized nonprofit board. It's a PACE program, and we are about reaching out into the community, and that's what I do for volunteer and give back. So I'm kind of curious, as a person who talks to a lot of CEOs and cornerstone kinds of organizations and politicians, how do I talk to them? What do I say to them about building a community around telehealth? Because I agree with this gentleman. I don't think the problem is delivery of care. I think it's the insurance. It's the paying for it in wrong, misplaced financial incentives. So I'm just curious about how do I talk about it? Is it too premature to talk about it?
So building a community is not a new idea. It's something that we actually did before and kind of moved away from, and now have silos all over the place. Of course, technology actually made us even more siloed than we were before, unfortunately, right? So people are much more isolated, unfortunately. I think that it is for the best interest to build communities because it creates stickiness to your organization. So if you are, again, I'll go back to Kaiser because it's the newest thing that I know, but Kaiser is very big about building communities around certain diagnoses. The reason is it creates stickiness for the patient. If I'm a part of a community, as an insurer, I probably will keep my patients around. They will want to come back and back to me because I'm giving them a value above and beyond just the insurance and the seeing of the doctor and the ER. I'm giving them a sense of socialization. I'm socializing them into my system. So it's actually not so premature. I think we need to start going back to that. It used to be that the doctor in the community was everybody knew him and everybody will go to that doctor, but people were talking to each other back then. We need to go to that concept, but we're doing it more globally. I'm your doctor, but I also have other people around me that can help you deal with your disease process. It creates stickiness, and so that's a very big point for CEOs and CFOs to say, well, yeah, I don't want people to leave my program. I want them to stay with me. That's a financial incentive. Okay. Oh my God, we have a lot of questions.
So I'm a primary care physician, and I don't really have too much time to counsel my patients on diet and exercise and weight loss. So I'm wondering, I see telemedicine as a way to use a team approach, and so to have a whatever nutritionist and that health coach. How have you seen telemedicine evolve into using a team approach?
I actually think that this is a perfect place for a team approach. So, if you take any platform, any telehealth platform allows you to bring more than one person to the conversation. So you can bring in the family, you can bring in the coaches, you can bring in the physicians, you can bring in the diabetic consultant. At USC, we did a program when we have, for diabetic, we had the diabetic educator, the pharmacist, the endocrinologist, the PCP, the patient, and it was for pediatric, and the parent. So there were 5 people on each one of those consults, creating conversations around how to deal with this child, type 1 diabetes. This is not, that's not uncommon. It's very doable. It's actually the same. It's just a matter of bringing the team together. And by the way, quickly for that, we created this community of 150 patients who end up growing up to 30,000. First type 1 first diagnosed diabetic children and their families that now are actually having picnics together and going out together, doing things together. But now they have this, they are not the only one with a child with diabetes. Now they have a community around them. That created a huge stickiness for this program, and this program is growing and growing. So that's bring it back. You can do the care team, you can do the community. You need to think outside the box a little bit, and it's not necessarily expensive. It's just a matter of utilizing your entire healthcare team. Okay? Thank you, guys. Thank you so much. I'll be around.
Thank you so much, Sigi.